that is bronchogenic carcinoma, also lung cancer to be more precise. They're asking you etiopathogenesis and also the morphology. Morphology includes both gross and microscopic features. Gross and microscopic features. Now, when you look at etiopathogenesis, the one thing that always comes into our mind whenever we talk about CA lung is smoking, which should be highlighted and it should be there in your answer. Okay, the smoking part. Now, apart from smoking, because not all the because you have in bronchogenic carcinoma, there are 4 different entities. You have squamous cell carcinoma, you have small cell carcinoma, and you have large cell carcinoma also, which is a separate entity, and you have adenocarcinoma, which is not related to smoking. The only 2 cancers which are related to smoking are squamous cell carcinoma and small cell carcinoma. Apart from that, there are other agents like radiation, mainly ionizing radiation, that is radiation carcinogenesis, and yes, occupational asbestos, mesotheliomas are more common here, asbestos, and yes, inhalation of gases like radium, exposure to metals like chromium and nickel. They're also the risk factors for causation of bronchogenic carcinoma. And there is one entity called scar carcinoma. In any old disease, old scars like TB scars, metallic foreign bodies, or wounds, or any irradiation, just radiotherapy we give, right? Any irradiation and all might lead to adenocarcinoma variant of CA lung. So what I'm trying to tell you here is that yes, you know that the etiology of bronchogenic carcinoma, the important point is smoking. Apart from that, there are also other etiological things. Now, many of the students, they get confused here. They only write etiology. It is etiopathogenesis. So you have to mention the pathogenesis. Now you can't discuss pathogenesis of each and every carcinogen. Here comes the question of how smoking or nicotine causes cancer. So that is a common question they ask. Like, so with pathogenesis part, so I would request you to majorly focus on, in the pathogenesis aspect or pathogenesis part, you have to majorly focus on one aspect, that is how smoking causes cancer. So smoking contains nicotine. Along with that, there are other carcinogens which are present in the smoking. So they lead to in the conversion of, once we inhale these pro-carcinogens in the smoke, they get converted into final carcinogens. Okay, and these carcinogens, they produce a specific effect known as field effect. That means whenever these carcinogens are inhaled, okay, so these are the lungs that we see, okay. So whenever we inhale carcinogens, so the whole bronchus, the whole trachea, the bronchioles, the peripheries, alveoli, everything is under the effect of or under the influence of this carcinogen. So it produces a complete field effect. So aerodigestive tracts have this special property. The field effect, we also use this keyword in the pathogenesis of oral carcinoma, right? So there will be a field effect. So because of this carcinogens, the key effect of these carcinogens is there will be inactivation of tumor suppressor gene, that is, which is present on 3p, and also there will be TP53 mutations, and also there is activation of oncogenes, that is KRAS oncogene activation. So all these leads to production or formation of cancer, okay, or carcinogenic change, right? Done. So in each entity there are different varieties. As I said, you have small cell carcinoma, you have non-small cell, which includes non-small cell cancer, which includes all the rest of the varieties. But to be more precise, you also have squamous cell carcinoma, and finally adenocarcinoma. Each variety or each entity has its very own, genes which get affected. So we are looking at those genes which get affected here. So with regards to small cell carcinoma, the genes which are affected are c-MYC and RB. So molecular pathogenesis. When they ask you pathogenesis, focus more on molecular pathogenesis. So I'm talking about c-MYC and RB gene mutations and also 3p deletions. Okay, non-small cell cancers, the major pathway is RAS and P16. To be more precise, if you want to learn about squamous cell carcinoma, P53 or KRAS, EGFR gene mutations are common in these things. There are other entities, but just remember these two. Okay, so these are the genes which are affected based on the histological effect, histological type of CL lung. Now coming back to the gross features. Okay, so the gross entity or the gross. So you have gross, you have microscopic appearance of CL lung. Okay, which will take one entity and we'll discuss, then we'll move to the next entity. First we'll start with, okay, the more frequently asked question in the exam, that is small cell CS, small cell. So you will see the tumor which is located centrally. Okay, I'm talking about a gross. Okay, centrally, and it looks on gross pale gray appearance of the tumor is seen. Pale gray appearance of the tumor is seen. Apart from small cell carcinoma, the other cancer which appears centrally in the sense in the trachea, in the main bronchus. Okay, main bronchus. If you take lung as a whole, okay, you have trachea, you have primary bronchi, right? So you will see central development of the tumor like this, central. Whereas adenocarcinomas, they usually develop peripherally. So squamous cell carcinoma and small cell carcinoma, they are central tumors, whereas adenocarcinoma is peripheral. Large cell carcinoma can be seen anywhere and it is diagnosis of exclusion. Okay, it's diagnosis of exclusion. Now, we are discussing gross features of small cell carcinoma. Then microscopic, the name itself says there are small basophilic cells. Okay, there are small basophilic cells. And now these are cancer cells. So when you have a small cell, it undergoes cancerous change. That means within that cell, you will see increased nucleus to cytoplasmic ratio. There is so much of bluishness to this cell. Okay, and these cancers, they are rapidly dividing. These cells, they rapidly divide. Okay, and then when they rapidly divide, what happens? I'll tell you. So for time being, you need to understand that there is an increased nucleus to cytoplasmic ratio, altered cell size, and they are not oriented in a straight line. Suddenly what happens? Some of the cells, they release their chromatin out of this thing, and in the vicinity there will be a blood vessel. And because of the increased nucleus to cytoplasmic ratio, because of the chromatin leakage, so this chromatin which is leaked because of the death of the cells are dying because of lack of blood supply, because as the tumor is rapidly growing, they form a circle, a bluish circle around the blood vessels. Okay, so basophilic staining of blood vessel due to chromatin leakage from the necrotic cells which are dying because of the deficient blood supply as the tumor is going rapidly. So this effect, what I am talking about, is important, and the keyword that should be there in your answer, that is Azzopardi effect, characteristic of our very own small cell carcinoma, right? Hope you got the point. So this is what you need to write. Apart from that, this chromatin gives an appearance of salt and pepper pattern, that you have to see it in an electron microscopy or deep microscopy. But Azzopardi effect and salt pepper chromatin, okay, salt pepper chromatin pattern are characteristic of small cell carcinoma. Apart from that, you have a third feature, that is small basophilic cell. Small, that's why we call it as a small. The other entity commonly asked in the exam is squamous cell carcinoma. Now with regards to squamous cell carcinoma, as I said, both small cell carcinoma and squamous cell carcinoma are central. Okay, major bronchi are involved in squamous cell carcinoma because it is majorly associated with smoking, right? Apart from central lesions, there are also one more thing, that is the lesions are cavitating as if there is a TB. Okay, cavitating, and these are mostly obstructive lesions. Obstructive lesions. Now coming back to the SSL microscopic appearance. See, I told you many of the times, whenever there is a squamous cell carcinoma is seen in lung, squamous cell carcinoma is seen in CE cervix, squamous cell carcinoma is seen in oral carcinoma. I am just limiting myself to the syllabus. So in the syllabus of UPSC, if there is any squamous cell carcinoma and if it is well differentiated, only well differentiated squamous cell carcinomas, they show a characteristic microscopic appearance, that is they have this keratin pearls, which you need to draw. So what are these keratin pearls? These keratin pearls are anucleate and there is no blue. There is no blue. That's why they are anucleate, pinkish, pearlish appearance kind of stuff. See, you can see the pink color, anucleate structure. This is keratin pearl, which is characteristic of squamous cell carcinoma, that too well differentiated. So any well differentiated carcinoma will show that feature, right? Apart from that, coming back to the we'll come back to this picture, which is very important, but for now we are discussing the gross and microscopic appearance. We are done with the gross and microscopic appearance of two entities. Let's go to the other entities now. Okay, now you have adenocarcinoma. Adeno is glandular, right? So how do you, any gland, if you want to draw a gland, okay, see, glandular per se, as I said, grossly it is peripherally located, and it is a small mass, small slow growing mass. Okay, sometimes it is nodular also in the periphery. Okay, these are the gross features. Microscopic features, yes, there is glandular differentiation. So any gland, you will see this is follicles will be there. Okay, and because this is a cancer, you will definitely see increased nucleus to cytoplasmic ratio, more and more bluishness will be seen, and on top of that, in the center you will definitely see the mucin or some secretion. Mucinous carcinoma we call it, as not always true, but definitely they secrete something. So glandular pattern will be seen, glandular pattern or follicles will be seen. Okay, so this is a different pattern, and if not glandular, there is other possibility can also be there. It can also show a papillary pattern like this. Okay, papillary, it can show a papillary pattern like this. Again, the same thing, you have to draw the nucleus in blue. I'm just, for the take of saving time, I'm just going with the red, but the papillary pattern can also be seen, okay, in these entities. This is glandular differentiation. Finally, large cell carcinoma, not that important. It's diagnosis of exclusion. They'll never ask a question on it. If it is not a small cell, if it is not squamous, if it is not adeno, we call it as large cell carcinoma. One important peculiar feature is it has a large cell, large pleomorphic cells, and there is no differentiation. It has a large pleomorphic cell with no differentiation. That's it. This is large cell carcinoma. Right? We're done with the lung. The same thing in the help of an image. So you see a sea of blue with small cell carcinoma, that is azopody effect. There is chromatin salt and pepper pattern, which is envisioning or encircling the blood vessel. Whereas SCC, you will see keratin pulse, as I told you. Adeno will have glandular or papillary pattern. Large cells will have larger cells. That's it. This is what you